This lecture is also a part of the Pediatric Pain Week. We normally run this as a pain symposium, which is kind of an all-day affair of lectures. But in order to try to address different resident groups, we're running it as a pain week this week. And so there are different lectures that are available all throughout the day. I'm well aware that most people are not going to be able to make it to these, but every single one of these lectures is being recorded and it's going to be on the Peds Pain website, which can be accessed through the Rainbow intranet. So if you have any interest in going back and maybe looking at some of these lectures, we've had the Pediatric Pain Service involved, we've had some people from adult pain involved, including Melinda Lawrence, as we're trying to address pain issues and do some education throughout the hospital, especially at the resident level. So what we found is that it's pretty easy for us to be able to find time to address the nurses and get the nursing staff on par to understand exactly what we're doing, but we're trying to hit different resident aspects and try to tailor each of our lectures to kind of what that particular resident or trainee group may be interested in. So later today there's acupuncture and pain. If anybody can get out at noon, this will be a nice one because they're actually doing some demonstrations. So I know that that's next to impossible for everyone here, but if nothing else, then these will be available on the net. Goals and objectives is we have to hit on every lecture. We're going to talk about a little bit of history and talk about the performance of regional anesthesia. And then I know you guys do this in adults and you guys do tons of patients and on the adult side, but the goal is kind of to give you a basic understanding of some of the differences and the key aspects of why the kids are significantly different than the adults. If we have time, we can touch on some of the resources that are available at Rainbow Babies for kids that are undergoing regional anesthesia. All right, anybody know who this is? This is a history lesson, a walk in time. I was going to bring a $100 bill and give it to anybody who could identify this, but then A, I didn't have time to go to the ATM, and B, I was like, oh my God, I don't want to be out $100 in case anybody's like a history buff. So this guy in 1898, he's a man who performed the first interaxial anesthetics on children. His first patient was a gentleman that he did, this was actually an adult, the very, very first one, that had some horrible experiences with general anesthesia, which you can imagine in 1898, general anesthesia was not so hot at the time, so he was super miserable, didn't want to go through a general anesthetic again. And so this guy was like, well, let's try something else. He injected 15 milligrams of cocaine intrathecally into the guy's spine and did beautifully. The guy was awake through the whole procedure. They were able to do it. It was a great show. Of course, the guy was nauseous, complaining of a headache for days afterward, massive back pain, leg pain, and was pretty miserable. So this gentleman did a series of 6 that were first published in 1898. The first 2 of those 6 were children under the age of 12. The children actually, unlike the other 4 patients, did not suffer the same sequelae of headaches and nausea and vomiting, which is an interesting observation already coming through in 1898. Any ideas from anybody's history buffs? What do we got? Who?
Corning.
No. All right, here's the story that's the dead giveaway. 1904, this guy also likes to practice medicine on himself, so he put a tourniquet on. Unfortunately, procaine was invented by this point. We didn't have cocaine. And he anesthetized his arm using a tourniquet technique.
Beer.
August beer. There we go. I figured I had to find something pediatric related, and he was kind of the oldest guy that had done something. And also an interesting story because he liked to do things on himself. Then we move into 1900 and 1910, and now we're in London. Dr. Gray is the man who published the first 200 cases, and these were all on spinal anesthetics in children. And what's interesting is that his conclusions in 1910 were exactly the same things that we know today. Got absolute anesthesia, and he actually didn't have any surgical shock, no hypotension, good operating conditions, constricted bowel. He found less post-operative pain and that feeding could be started sooner on these children than all the ones that he'd operated on previously. So interestingly enough, we're still examining some of the same issues that these guys were looking at back a century ago. For most of the 1900s, we really didn't look much at regional anesthesia. Nobody really cared. because this is when the general anesthetics started getting better. I mean, once you've got thiopental, cyclopropane, halothane, these were all invented 1930s to 1950s, and then halothane was pretty much used for a pretty long time. Through the 1970s and 80s is where we started getting some increased attention and interest in regional anesthetics. Whoops. So as Dr. Tribby mentioned earlier, we are really working at Rainbow to increase our regional anesthetic use. Back in 2010, before we started the pain service, we did about 11 neuraxial anesthetics and about 2 or 3 regional blocks in apprentice ORs over the course of the year. We don't have accurate numbers, granted, because we weren't keeping as good of track of it by then, but now we're upwards of close to over 200 peripheral nerve blocks and about 100 to 150, kind of depends on which data you look at, for epidurals, which include thoracic and lumbars, and none of this data includes caudals. The goal was, and at the beginning when we first looked at this data in 2012, it was really cool. You saw like this upswing in Press-Ganey scores going along with our upswing in regional anesthetics, but that kind of tapered off. So it's kind of hard to prove an improvement in patient satisfaction, because as soon as you improve one thing, then, you know, if the breakfast isn't good, then all of a sudden everything drops on your Press-Ganey scores. So we're trying to, it's really hard to be able to prove that you're improving patient and provider satisfaction. But on the provider satisfaction side, we've had a lot of buy-in from our surgeons, which is nice considering that 5 years ago, we really weren't doing this. And now the surgeons are coming and looking for us and saying, hey, I've got this kid coming in, can you make sure that something happens? So if anybody's going to ever be going out, starting any programs, or really trying to push for regional anesthesia in a new hospital, it's totally doable. It's a long road, takes a lot of surgical buy-in, but you can really get them on board. So why regional anesthesia? And I mean, this is something that you guys face on the adult side all the time also. We know that it provides excellent pain control. Plenty of studies have shown that it reduces your need for opioids and other analgesic drugs, superior pain relief, and then also on the pediatric side, the pendulum may start really swinging toward the regional anesthetics. Right now, and as you guys know in the literature and what's going around even in the lay press, there are a lot of concerns about the neurotoxicity of general anesthetics and the potential of children, especially under 3. If you have 1 or more, or 2 or more, general anesthetics, studies have come out that are showing that there's an increased incidence of the development of learning disabilities. These are hard studies to do, right? Because children who probably need surgery at critical points in development probably have some other things going on. So it's really hard to tease out some of the issues. But there are some major studies that are going on right now, some prospective studies involving thousands of patients and multiple sites, including PANDAS and GAS, the results of which will be coming out really in the next year or 2. SmartTots.org is basically saying, you know, if you can do a regional, that's great, but unfortunately, as we know, we can't necessarily do just a regional without the general anesthetic as well. But it's going to potentially really be propelling the interest in regional anesthetics. So, children are not small adults. We're going to hit on the differences with anatomy, physiology, pharmacology, and psychology. I wanted to find a picture of John Stork and do this and like do some photoshopping, but you know, that would have been a lot of work. These are so hard to go through and make the least bit interesting because these are kind of lists of facts. So some of these facts, though, are things that pop up in standardized tests, so you still have to kind of be aware of them. Lower termination of the spinal cord, lower projection of the dural sac. Those kinds of things always pop up on your board exam, so keep that in the back of your mind. Anytime you do an epidural or even a caudal, there's an increased risk of inadvertent penetration of the dura mater and the caudals, and then there's an increased risk of direct trauma to the spinal cord. It's been said that inexperienced providers, anybody who really doesn't have much experience in children, should probably stay away from any high lumbar or thoracic epidurals. The delayed myelination of nerve fibers in children up to age 2 leads to easier intraneural penetration of the local anesthetics. What does that mean? It's kind of like all fancy talk. Basically means that you have a shorter onset time, that you can use very dilute solutions that are very effective. 8% will provide you not necessarily surgical anesthesia, but you'll get pretty close to almost even having a motor block. You will see leg weakness even at an 1/8 percent solution going in on an epidural, which I'm pretty sure generally on the adult side you don't see that much leg weakness at that low of a concentration. The lack of fusion of the sacral vertebra gives you persistence of the sacral intervertebral spaces, which is what allows us to do the caudals. Delayed development of the spinal curvatures. So basically these babies are flat the whole way through. You don't see the lumbar or thoracic curves, which gives you the same needle orientation, because on adults you're going out that really steep angle. In a thoracic, in peds it's pretty much perpendicular the whole way up. The other thing to note that in children, and this is interesting because we'll see an example of a spinal that's being done later in this, later in the presentation, where I'm not quite sure what he's doing, but we've got the line, the intracrustal line, right, where everybody says is like 3-4 in children and adults. You're actually at L5, S1 at that point. So you just kind of need to know. It'll gauge, you're counting off your spaces a little bit differently. So that the line at the iliac crest, intercrustal line, isn't as high as you would think it is. The increased fluidity of the epidural fat leads to increased diffusion of your local anesthetics. And then a key one in pediatrics is that the sympathetic immaturity, the diminished autonomic adaptability of the heart, and a small lower extremity vascular bed leads to hemodynamic stability. We don't need to fluid load our patients before epidurals, or I guess spines also, intrathecals in pediatric patients. They really don't drop their pressures. Other anatomic features, these are also testable items. Your total volume of CSF in a neonate is 10 mLs per kilo versus 2 mLs per kilo in an adult. 50% of the total CSF is in the subarachnoid space versus 25% in the adults. So that means that your local anesthetics get quickly diluted. You give higher volumes based on weight, but the duration of action is shorter. So off of spinal anesthetics, you're looking at about 80 minutes of maximum surgical time. So that's why it can be kind of hard, especially in teaching hospitals, finding the right patients to be able to do an intrathecal anesthetic on, because you really are very limited by that time frame. And then if the whole goal is to prevent the addition of any additional drugs, including midazolam, ketamine, then you're in this problem of you can still be providing neurotoxic drugs, but you're going to run out of your spinal anesthetic, so you've really got to pick your patients carefully. Narrow intraepidural space. Kids have higher intraepidural pressures. What that means is that after we thread an epidural, then we see a lot of leakage. So what we've chosen to do is that we just put like some Dermabond basically at the entrance of our catheter. Basically prevents that back leakage. If we don't have that there, what we've noticed is just a lot of our fluid keeps coming out. Is that a problem? No, but it just causes a messy bed, it causes your dressings to come off, and it causes the nurses a lot of concerns and a lot of phone calls. So we try to minimize that aspect just by being able to kind of patch that hole as much as possible. Don't think that's something that you're generally liable to see on the adult side. Other aspects of importance for before you start doing an epidural block is the depth. This isn't like, let's shove in the needle, try to find where we are, and then you're already 3 centimeters before you're really in ligament. You don't have that much room. The easy cheat for us to remember is just 1 millimeter per kilo for epidural space in ages 6 months to 10 years. So in a 10 kilo kid, you're going to be hitting that epidural space at about 1 centimeter. So this is why we're doing these very carefully, very slowly, and with much smaller equipment. I already mentioned this, that we have the diminished autonomic adaptability and the immature sympathetic nervous system. Again, children less than 5 don't show that sympathectomy and don't show that hemodynamic response. This is something that, again, was proven already in 1898, and we still keep seeing it over and over. It's interesting because former preemies or even infants that have spinals, they tolerate these things with very, very few blood pressure and heart rate changes. We also see a shorter duration of action on our local anesthetics due to the increased cardiac output and heart rate. Pharmacology features, and these are the aspects, these are also, if people want to wake up if they have a test that's coming up or anything, these are also issues that show up that are testable concepts Children have a lower plasma protein content. Basically means that you have an increased amount of free fraction of your local anesthetic and an increased danger of systemic toxicity. So basically when you've got like a 10-kilo kid, you're running your epidural infusion rate at 3 mLs per hour. So don't be bolusing any more than 3 to 5 mLs, which is sometimes hard if you're coming from a different perspective of you've got a much wider range of systemic toxicity, and you usually don't have to ever worry about necessarily hitting that toxic dose. Enzymatic immaturity also means that you have slower metabolism of your local anesthetics. We talked about the fact that there's a shorter duration of action because of the cardiac output and heart rate. The increased extracellular volume leads to an increased distribution volume. So what happens is that after continuous infusions, there's a buildup of local anesthetic. It accumulates, and so then after it's turned off, you still have that decrement that you need to wait for. And again, we see more accumulation with repeated doses because of a slowed elimination half-life. Everybody's putting something into their epidural solutions right now, be that morphine, fentanyl, clonidine. People are experimenting with dexmedetomidine, buprenorphine. I mean, pretty much everything you can think of has probably been thrown into an epidural solution at one point or other with, questionable benefits in the literature as to whether this works, doesn't work, whether it's approved in the US or Europe, and what people are doing. But the two general ones that we usually stick with are the opioids and clonidine. Opioids, what we remember on the ped side is that our elimination half-life is increased in the neonates and infants. And with clonidine also, everything is slowed, so we're using everything at much lower doses. There have been some instances of respiratory depression in neonates and small infants. Clonidine is normally very, very safe. There were some studies published where, and I can't believe they actually published this, they had the guts to publish this, but at a Texas Children's Hospital, 2 children were massively overdosed clonidine, and I believe it was in a caudal, they were doing a caudal, and one child received 1,000 times the intended dose, and another child received 100 times the intended dose. The beauty of it was they just went to pick you like overnight, and they woke up and they were fine. So oddly enough, there's really no toxicity that's associated with it, but boy, did it prolong their hospital stay. So don't send the kids home after clonidine anyway, even at ordinary doses, but it is nice to know that you do have that very significant buffer. So back to basic pharmacology, which is always painful to listen to. We have our esters and our amides. Our esters are metabolized by the plasma esterases. In children, we have decreased plasma levels of these esterases. However, that's not been found to be of clinical significance, even though it would theoretically decrease your ability to metabolize. It is implicated in allergic reactions. We use tetracaine for our infant spinals, and chloroprocaine is recommended in any neonatal spinals or epidurals. Amides. These are the ones that are a little bit more interesting because bupivacaine and ropivacaine are generally very highly bound to our proteins in blood. Alpha-1 acid glycoprotein has a very high affinity for the local anesthetic, even though it's not present in such a high amount. And albumin is in a high volume, but it has a low affinity for local anesthetics. However, both of these proteins are very, very low in our infants and children. And unfortunately, it's your free fraction that's physiologically active. We do reach our adult levels of binding at about 1 year of age. But in that 6-month range, we're significantly dropping our dosings in order to compensate for the fact that we're not able to metabolize our standard drugs. In addition, cytochrome P450 is the metabolism pathway for our amides, and that is significantly decreased in the infants. This is something that probably, if you're going to be on the ped side intermittently, you're going to look up before starting kid on an epidural. We usually have little cards, or we look it up to know exactly what we need to be doing. Single doses, not so bad. It's pretty much the same everywhere, 3 milligrams per kilo. Our continuous infusion rates, we're never really running anything above 0.4. In any child under 6 months, the automatic action is to decrease by 50%. We see much higher plasma bupivacaine concentrations in this age group for all the reasons that I kind of already talked about with the decreased clearance, the increased free fraction. So we're always dropping those significantly. So a 6-month-old who is, let's see, one of the ones they did was like 4 kilos. I mean, we're running that at like 1 ml per hour on your infusions, and these are going through 24 gauge catheters. So these infusions cannot be stopped or the catheters will clot off and then you've got nothing. I couldn't go through this without touching on the time-honored epinephrine test dose. And this is another testable item, and that's really kind of the only reason I hit it, because I figured it was kind of important to mention. We always do a test dose. It's out of habit, and it is out of the fact that there should be some response. The ordinary criteria is a heart rate increase of 20 beats per minute. However, in children, we found that our sensitivity is significantly altered by inhalational anesthesia. That sensitivity can be improved a little bit with pre-medication with atropine, but that's not necessarily common practice that any of us are doing. So the positive response rate for children that are anesthetized with sevoflurane, you have to look at that T wave. I mean, nobody's looking at the T wave. You know, you're injecting your medicine and you listen for any changes in your heart rate, but nobody's really looking up at their EKG monitor going, I wonder if that T wave has changed. So that's really the best method to be able to identify it, because it's only a 71% identification of an intravascular injection, and that's even dropping your heart rate increase to 10 beats per minute. There's this new generation of pulse oximeters, which are also being used in some institutions, and these are apparently a very sensitive means of identifying intravascular injection, whether or not the children are anesthetized with full MAC or half MAC of sevoflurane. And it significantly showed this decrease in your pulse wave amplitude that was pretty apparent after 5 minutes after injection. The problem is 5 minutes after injection, you're not going to be sitting there usually on your small volumes and waiting for 5 minutes. Some of these studies are much easier in a study type of situation than in reality. Psychology. And here's the crux of the difference between peds and adults. So because of different pediatric behaviors, we cannot do our blocks awake. I mean, intrathecal, neuraxial, peripheral nerve blocks, we're not doing these in awake patients, which is exactly what is not allowed on the adult side, and that continues to be true. Fortunately, 2 problems are created by this. One, we can't identify a paresthesia, and then does the general anesthetic agent affect the ability of the test dose to identify the accidental intravascular injection, which we already talked about with the epinephrine? Yes, it does. It significantly changes whether or not you're going to be able to see any major differences. So, brings us to the question of, is this advisable? I mean, are pediatric anesthesiologists crazy? I mean, how is this okay? So first we have to look at a couple of ideas of what we're expecting. So we think that, what is it that you do when you're putting in an epidural, like on a labor and delivery patient, you're about to bolus it? Tell me if you get a funny taste in your mouth, if your legs feel heavy, if all of a sudden you get that tingling. So all these are objective measures that we're expecting a patient to be able to tell us about. However, it's been found that subjective signs of this toxicity are unreliable even in mildly sedated patients. So that means even if you're giving a patient just some fentanyl and Versed pre-op or pre-procedure and you think they're awake, these subjective signs of local anesthetic toxicity, even on the adult side, are still unreliable. So general anesthesia is thought to be protective for your CNS effects, but it does contribute further to the cardiovascular toxicity. So again, problem, but maybe that's actually a benefit for us, because if we're going to inject intravascularly, at least we'll prevent a seizure. It's a thought, but there's no real good answer to that one. Then there's the assumption that if you have a paresthesia, when you're placing either a nerve block or an epidural or an intrathecal, then that's your early warning sign. Oh my gosh, that hurts. You're like killing me. They feel that sharp shooting pain going down the side. Is that a problem? Is that going to be an indication that if you continue, then you're going to cause permanent neurologic injury? So these paresthesias are relatively common. Yet, whether or not you have a paresthesia, you may or may not have a negative outcome. Not having a paresthesia, you may or may not have a negative outcome. So no atypical sensations can still lead to having problems The problem is that any true paraplegia or nerve injury issues are very, very, very rare. And so your ends have to be so high to really even be able to differentiate this. However, the general ASRA guidelines indicate that the paresthesia or pain on injection isn't really sensitive or specific of nerve injury. So our large-scale studies of sleeping regionals, these are all done in Europe. The French Language Society is the major one. This is 55,000 patients, all of which were done asleep. They found no complications related to peripheral nerve blocks and a 1.5% complication rate of the central block. These complication rates were not significant. There were no paraplegias, no death, no epidural abscesses. The complications that were recorded were far more minor, but still recorded as complication, including urinary retention, complaints of movement disabilities. There were a few cases that needed a little bit more time for resolution, but nothing was permanent. The National Pediatric Epidural Audit, this was done, I believe, through English-speaking countries in Europe. This is 10,000 epidurals, all of which, again, done asleep. There were 3 incidences of infection, and then, what is that, about 20 minor injuries, so 56 serious adverse events were noted. Your numbers are not significantly different when the kids are asleep. Now there's a consortium, PRAN, the Pediatric Regional Anesthesia Network. This is a group of institutions, I believe it's 10 or 12 right now. It's not that many institutions necessarily participating with their data inclusion because it's about a $5,000 cost per year to participate. But your larger institutions who do a lot of children are definitely participating in this. The most recent, and this has only been going on for about 4 or 5 years. Their first data was recently published, and they saw 15,000 regional blocks. 95% of them were done under general anesthesia. They broke it up into single injection issues and continuous issues because your complications vary whether or not it's a single injection or a continuous. So 93% of the caudals, so 40% of single injections were caudals, 35% were peripheral nerve blocks. And they found a 3% adverse event rate with a 57% inability. So of that 3%, 57% of that is an inability to place the block or block failure and a 2% block failure rate. So really very, 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 very safe to be doing these blocks asleep. On your continuous blocks, fewer, 18% adverse event rate. Catheters showed 26% block failure rate, and I think we see this pretty regularly on the adult side also. The failure rates are generally due to kinking or catheter dislodgement, problems with that. There were 11% of patients had local inflammation or infection, so redness and swelling around the area, but none of those led to deep infections, abscess, meningitis, any of those really scary things that we're always on the lookout for anytime we have a neuraxial catheter. They did have some neurologic issues where there was some weakness that persisted post-op. All of these sequelae resolved within 3 months. So the most recent ASRA practice advisory was just published. I think it was September, October 2015 in the Journal of Regional Anesthesia and Pain Medicine, basically saying that the benefit of ensuring a cooperative and immobile infant or child outweighs the risk of performing neuraxial regional anesthesia in pediatric patients during general anesthesia or deep sedation. Those recommendations are still not the same as adults because on the adult side, you're still going to want to have that adult patient. It's just on the pediatric side, we're not going to ever be able to take a needle and stick it into an awake child and expect any level of cooperation. So it's a matter of risk-benefit analysis. Because on the adult side, again, neuraxial regional anesthesia or interventional pain procedures should be performed rarely in adult patients whose sensorium is compromised by general anesthesia or deep sedation. So I wanted to move a little bit onto the practical aspects of doing these blocks. Points to consider, and this is kind of a little bit of a heads up for any rotators over on the pediatric side. The child is not the person to practice on. You've got to practice your skills on adults. None of us is going to hand over a 3-centimeter 2E needle on a 10-kilo baby and say, here, have at it. You've got to really have that feeling on the adult side of how to perform an epidural or any neuraxial procedure before trying it on a small patient, because the feeling is very different and you have to have at least a certain skill set before moving on and doing it in small children. Peripheral nerve blocks, obviously not so much. I'll tell you that peripheral nerve blocks, this is where the statement of, children are not small adults doesn't necessarily apply. I mean, your nerve structures are smaller, everything's closer together. You do have some vascular structures closer by, but it's generally the same concept. And we're usually not doing peripheral nerve blocks in, I don't know, I'd say 1.5 to 2 years is really the lowest age range that we've been doing it on. Got to have supportive surgical colleagues. This is if you're going anywhere into private practice and wanting to introduce more regional techniques than perhaps is being done in your current situation. You've got to get your surgeons on board. This gets your patients on board. They're able to talk about it ahead of time, and it only takes a few patients where they see that difference post-operatively, and they will suddenly tolerate those longer induction times. Because again, all of our cases are being done before the surgeon touches the patient, right? So they're looking at, well, it's going to be another 20 minutes before you're able to start. And in general, they're fine with that. They start tapping their feet around 25 to 30 minutes, but I guess you can't blame them. You got to have more people in the OR if you're going to be doing regional blocks and sleeping children. Somebody's still got to be paying attention to that to the general anesthetic. So your child can't necessarily be totally unmonitored because you can't pay attention to the procedure that you're doing and what's going on up at the head of the bed. So it's important to make sure that you've still got people around to be able to pay attention to that aspect of the child. This is a major point that we had to work through at Rainbow, and this is going to be true pretty much anywhere you go. I mean, you would think that, well, we've been around for so long and Rainbow's a good hospital, and yeah, we've only been introducing regional anesthesia here for 5 years. So there are plenty of hospitals that are still on that upswing, and if you're going to be going anywhere, things to consider include your nursing policies and procedures. You've got to have your nurses on board with everything that you're doing too, and there's got to be nursing education that goes on. That goes for the floor nurses who are going to be managing your epidural pumps, and that goes for PACU, who needs to be taught about how to discharge with residual motor and sensory block. And there's a little bit of a judgment call on assessing your patients and the parents and the family to be able to see whether they can truly understand and really get the idea of your child's extremity is numb. Keep space heaters away from them. Watch them when they're crawling, for that first 8 to 10 hours. It seems so obvious to us, but for the families, it's well, they don't seem like they hurt. They must be okay. And so things like that are not considered, and patients come in the winter times. Frostbite is a consideration where they don't feel it, and so therefore they come in and that extremity is suddenly injured. Burns are obviously the other one. Proper equipment. Spinal anesthetics done with very teeny tiny itsy bitsy little needles. The needle that you guys got your flu shot with, that little teeny tiny thing, that's what we're doing spinals in the under 6-month range. That's what your CSF is flowing out with. Caudal anesthesia, in order to be doing this, you can't use the big 10-centimeter adult kit. Trying to do that in like a little child, I mean, you could try, but A, your catheter is going to be really big, and then you're going to be like this far away from a tiny patient. Not a good idea. Make sure you've got the absolute right supplies before going into anything. Again, peripheral nerve block, same as adult. Continuous catheters. I'm actually really excited about the continuous catheters, and I don't know if this is kind of a plug for our reps that come through, but we just got these Pyant kits, and I think they came through on the adult side too, where they're, instead of doing, normally we do a Seldinger technique, right, for putting in a catheter where you access your needle under ultrasound, and you've got that, and then you thread your catheter and you take out your needle while holding on to that catheter, hoping that you're not dislodging where that catheter lies. So now they've got this thing where you put in under ultrasound guidance, they have an echogenic needle that's encased in a plastic sheath. You take out the echogenic needle, the plastic sheath stays in place, and then you put in a catheter that just sticks out about that far beyond the tip of the needle. So it's really cool, great for like paravertebral blocks especially, because anytime we've and I don't know, maybe you guys have had an easier time on the adult side with paravertebral catheters. Anytime we've tried the paravertebral catheters, we just can't get it to go in, and then you're trying to thread it in and you don't really know where you've ended up because you have a very small amount of space there. So it's nice to be able to have everything kind of secured in one spot. So they're pretty cool, and I think that you guys have them too. So I'm just going to go through just a couple of, again, practical considerations. Caudals, epidurals. I don't know if I touch on nerve blocks at all. Again, history of pediatric caudals. This really started around 1933. There may be some history earlier. The Egyptians were using something for circumcisions once upon a time, but I couldn't find any documentation to be able to see exactly what they were doing. So the published literature really starts around 1933, where we're seeing an 80% success rate in children that were given caudals instead of general anesthetics. Caudals, ridiculously safe. Major studies have shown very low complication rates that are not significant. These complication rates are things like, well, the child couldn't really crawl afterwards or couldn't move his legs or had some urinary retention. These are kind of expected side effects of the caudal as opposed to adverse events. And to date, there's been no epidural abscess, hematoma, or paraplegia in a single shot caudal in the world's literature, which is why we're probably all very, very comfortable with this. Since you guys do so many, and anybody who rotates on the pediatric side has obviously done a caudal before, but I thought this video was neat to actually see what it looks like when you're going through it. Now, in previous slides, 93% of caudals are not done under ultrasound guidance. So this is purely kind of just for educational purposes, but you can see that needle coming through, and pretty soon here, there we go. We're going to be injecting the local anesthetic medication. You can see that spread. There's really no indication to be doing these under ultrasound, but it's still kind of neat to be able to see exactly what you're doing. Pediatric spinals. So this is again, a little video of exactly what it looks like when you're doing something on such a small little baby. And this quality is absolutely terrible. Sorry about that. Couldn't tell really what I was pulling off the internet, apparently. I would have videoed something like this here, but unfortunately, I've yet to do this. And so this is as much for me learning as it is for everybody else, because I actually have never done a pediatric spinal. I had one colleague in fellowship who literally came to the program because all he'd done as a resident in his program for infants was spinals. He had never done an infant under a general anesthetic, so he wanted to see how you manage those. This is up at Vermont, where they really are really heavy on the neuraxial anesthesia, and especially in infants, preemies, babies. And so that's your 26 or 27 gauge needle going in on that baby and getting your CSF leak right there. Just give you a really good, like the visual, it does a whole lot more than just telling you, oh, this is what you do. Oh, and then you have to make sure that your needles are actually being able to fit into the hub. This is important because in 1898, going all the way back to our history, so August Beer liked to experiment on himself, as we know from his beer block, but when he was trying to figure out neuraxial anesthesia, he actually had his assistant performing these on him too. And one of the stories is that his assistant got the loss and then has all this CSF dripping out, can't attach the hub of the needle, is trying to get that cocaine onto there, and he just couldn't. And so then the guy's out for like 9 days, massive headache, couldn't do anything, and just felt absolutely miserable. But did recover without sequelae, if it makes you feel any better for your post-dural puncture headache patients. Pediatric spinal dosing, I don't expect you guys to remember this. This is just kind of how to be able to create these mixtures, because you're not going to be getting any hyperbaric mixtures generally from pharmacy, or at least I don't think you are. We probably wouldn't. Pediatric nerve blocks, again, any blocks can be performed in children with the appropriate indication. You just have to remember that your targets are going to be smaller, closer together. And the nice thing about the peripheral nerve blocks is that you get a much longer lasting analgesia. So if you're considering, for example, a single shot epidural or a single shot caudal, if there's an option to be able to put in a peripheral nerve block instead, even as a single shot, that's going to give you a much longer duration of anesthesia. Extremity blocks, you need a good 30 minutes for that to really become established, which can be unnerving if you put in your block and you're waiting, your surgeons have already gotten started, and you're like, man, is my block working? It can really take that long for the block to set up in kids after induction. It doesn't take quite that long on the adult side. This is just something that if you guys want to access this lecture later or pull it down, it's a little just to remember the different blocks that are appropriate for particular indications, because sometimes you sit there and go, okay, this is where their incision is, what is the dermatome supplied by, and which nerves do I need to block? And so it's just a general idea of the blocks that we do on a frequent basis. We don't actually do so many brachial plexus blocks. There are very few indications in kids for it. We'll do it for clavicle fractures. So that's actually a nerve scaling block. But for our ORIF elbows, some institutions are doing this, but because of the need for the surgeons to be able to evaluate postoperative neurologic function, in addition to their very high concerns for compartment syndrome, there are actually some institutions that don't even give opioids after their ORIF elbows because they're so concerned, their orthopedic surgeons are so concerned about the potential of missing compartment syndrome. So, you know, as much as we've tried to get our surgeons on board for some blocks, there are some that we just don't do. And for example, our elbows we haven't really pushed for. One of the ways to get around an elbow in the postoperative examination, if they're not so concerned about the compartment syndrome post-op, is to access your space, access everything under ultrasound while the patient's asleep, put in just an angiocath there, hub it, leave it taped up, and then put in your local anesthetic medication in PACU after the surgeons have been able to get their evaluation. So there are sometimes ways of getting around it, but you kind of have to know when it's okay to push and when it's not. Same thing goes with some of our tibial osteotomies and the tibial fractures because, again, of the concern for compartment syndrome. Continuous infusions, the key for the continuous infusions is that we drop our rate significantly and drop our dosing in young children. We're generally not putting in these kinds of blocks in the under 6 months range, so we don't really need to worry about any accumulations there. And this is really pretty standard and the same things that you guys are using generally on the adult side. I'll tell you, most of us are using 0.25% and not going up to, there are recommendations of over 5 years old to be able to go up to 0.5% and 0.375%, which is I think what the adult side generally uses. But because we're limited to our total dose of bupivacaine to less than 3 mLs per kilo, then we need a certain amount of volume in order to be able to ensure an adequate block, and it's better for us to go down on our percentage than it is to increase our percent and decrease our volume. And that's it.